Hello everyone. Pathway Hematology. Please go ahead when you're ready.
Okay. Hello everyone again. My name is Dr. Ayman. Me and Dr. Maha are going to present for you today hematological diseases and disorder in elderly. We're going to start with the objectives. First, we will discuss how hematopoiesis changes with age. Secondly, the classification and workup of anemia, and then rational use of exogenous erythropoietin and indication for vitamin B12 folate replacement, and finally, how to identify and treat thrombopenia and thrombopathy, clotting factor deficiencies, and chronic myeloproliferative disorder. So we're going to talk about how aging affecting hematopoiesis. With age, both overall number of stem cells and the rate of cell division increase, which is something unexpected. But functionally, this hematopoietic stem cell seems inferior. And according to my literature review through articles that published recently, they found that with age, changes take place in bone marrow hematopoiesis that can have an impact on health and longevity. Overall, human stem cells seem to become more poorly functioning and possibly as a result have an increase in both their number and cell dividing capacity. Regarding the white blood cells, the myeloid skewing also become apparent with age and may contribute to the increased rate of myeloid malignancies in elderly. This skewing, coupled with a reduction in T cells production, result in a decrease in lymphocyte, which may contribute to a decrease in immunity that's seen in elderly. But regarding the red blood cells, the erythroid progenitor do not seem to decrease with age. So we ask ourselves what the cause or what they make the elderly more prone to anemia. So they found that the increased rate of anemia may be explained by change in the response to erythropoietin. And also, there are more variable responses to stressful conditions. So hematological abnormalities are likely to occur earlier, but more severe than in younger people. As example, we expect that slower return to normal hemoglobin following phlebotomy and also reduced ability to mount granulocyte response to infection. So with aging, making the person less adaptable to stressful stimulus. And also, again, they found that in ideal situation, when there is no comorbidities, there is no significant change in basal blood counts. Then, modest increase in prevalence of anemia, especially in men, mild increase in the circulating erythropoietin to overcome the receptor resistance that occur with aging. And they found that in the absence of comorbidities, response to injected growth factor as erythropoietin or hematopoietic growth factor seems to be unaffected. Here we're talking about epidemiology. So the anemia is the most common age-related hematological abnormalities, affect between 12 to 16% of women and 18 to 22% of men after age 80, especially prevalent in older adults who are hospitalized and who are seen in geriatric clinic or are institutionalized. I say that it needs to be coincident with other comorbidities or something that make the elderly on stress to feature these type of anemias. Clinically, and the presentation of anemia when hemoglobin is less than 10 gram per deciliter is associated with anemia of chronic disease or inflammation, which is the most prevalent type of anemia in elderly. But doesn't prevent that we consider other possibilities as blood loss, malnutrition, folate deficiency, and hemolysis. And one of important investigation that sometimes we need to do is bone marrow exam, and because some of those results are often equivocal. Coming to the classification of anemia, we can classify is one we can find different classification according to the source that we read from, but one of the commonest is according to hypoproliferative anemia that include iron deficient erythropoiesis, include both iron deficiency and chronic disease, erythropoietin lack that include renal and endocrinological disorders, stem cell dysfunction, and lastly, aplastic anemia. Also, ineffective erythropoiesis that include macrocytic anemia that include both B12 deficiency and folate deficiency, and myelodysplastic syndrome, which can be macrocytic or normocytic, and microcytic anemia that includes thalassemia and pseudoplastic anemia. And lastly, as we mentioned before, myelodysplastic could be also normocytic anemia. Also include this classification, hemolytic anemias could be immunological as idiopathic or secondary to infection or drugs or other malignancies. Intrinsic could be metabolic or abnormal hemoglobin. And lastly, extrinsic, most commonly mechanical. So going to workup of anemias, practically speaking, when hemoglobin of 12 gram per deciliter is lower limit of normal for older men and women, clinical judgment is important in deciding how aggressively to evaluate borderline for hemoglobin. Principle of evaluating anemia do not vary based on patient age, so our approach to patients who have anemia is similar to younger age as elderly. So as we always say, the first step going through history and physical exam to detect the clinical pictures and also detect the risk factor that precipitate the anemia. And the first and foremost is the CBC to confirm the diagnosis of anemia. So after confirming the anemia, we'll always look into MCV to decide which is microcytic and macrocytic or normocytic. And here I always prefer this approach that when you see the MCV to put in your mind the differential diagnosis according to the MCV. For example, in microcytic anemias or in microcytosis, we consider the pathology that affecting the globin part, which is thalassemia, or affecting the heme synthesis, which include iron deficiency, anemia of chronic disease, and sideroblastic anemia that include lead poison. And in macrocytosis, we can divide it either into megaloplastic or non-megaloplastic anemias. The non-megaloplastic, we consider liver disease and chronic cold overuse. And in megaloplastic, the most common is the nutritional deficiencies of B12 and folate. So we also look into reticulocyte production index, which is helpful to differentiate the hemolytic anemia from non-hemolytic anemias. Here we have a flow chart that illustrates uh, our approach if we're suspecting a patient who having B12 or folate deficiencies. After confirming the anemias and looking into the serum B12 and folate, in left part, if B12 show low level of less than 150 picogram per ml, this is confirmed B12 deficiencies and we treat accordingly with parenteral or oral B12. On the opposite side, if folate level show low level of less than 3 nanogram per ml, this would confirm the folate deficiencies and we treat accordingly with folic acid. But if the level show indefinite range, we look into some of famous metabolite that we can differentiate between B12 and folate, which is methyl malonic acid and homocysteine. Let's go back a bit to biochemistry and to see the role of homocysteine and MMA in those type of anemias. The homocysteine, as we know that when B12 and folate participate in DNA synthesis, they pass the methyl group into homocysteine to change into methionine. Any deficiency of B12 or folate will lead to homocysteine to accumulate. But B12 also participate in other reaction that help methyl malonic acid to transform into succinylcholine, and this reaction require B12. So, according to those levels, if MMA elevated, which is unique for B12 deficiencies, this will show this is will confirm B12 deficiency, and we need to treat accordingly. But if MMA was normal and homocysteine is elevated, this would confirm folate deficiency, and we need to treat accordingly. But if both are normal, we should need to investigate more for other causes or possibilities, and we sometimes can consider bone marrow biopsies. This slide showed the ion profile and how it helped in differentiation between iron deficiency anemia and anemia of chronic disease. And we can talk about it in the next couple of slides. So first, we're going to tackle the iron deficient erythropoiesis. As we mentioned before, it includes both iron deficiency anemia and anemia of chronic disease. So in both of them, we'll find that decreased serum iron and reduced transferrin saturation. But in younger people, the most common cause is absolute iron deficiencies through blood loss, and which showed low serum ferritin and high total iron binding capacity. But in older adults, the most common cause are anemia of chronic disease, and which show high serum ferritin and low total iron binding capacity or normal total iron binding capacity, because in the pathophysiology in chronic disease and inflammation, the acute phase reactive hepcidin will lead the ferritin to be accumulated inside the macrophage and prevent the intestine from absorbing extra iron. So it could be a bit similar, but we need to differentiate between them because nutritional iron deficiency is rare in older adults. So unexplained iron deficiency in older adults is almost exclusively due to GI blood loss. So we need to do more investigation because common causes of iron deficiency anemia in elderly may be due to angiodysplasia, flat bowel, and diverticular disease. So if we are suspecting iron deficiency or confirm anemia due to iron deficiency, we need to do further investigation to exclude also other causes as neoplasm. So blood loss anemia showed low serum ferritin and high total iron binding capacity. Regarding anemia of chronic disease, laboratory features show mild anemia, low serum iron, low transferrin saturation, and normal to increased iron stores. So occasionally, the initial manifestation of occult disease will be anemia of chronic disease. So distinguish, as I mentioned before, iron deficiency anemia in order to avoid unnecessary GI tests and oral iron therapy.
Ah,
Here,
who
we're going to talk.
wrote all of this stuff? IBS patients are keeping our struggle. And I'm not talking just because I'm a physician, but moreover, I'm talking also because I'm an IBS patient. So it's so devastating. And it's so bad feeling when you sit between people in gatherings and meetings or whatever kind of gathering is, and all people are like laughing and discussing something, and if you have bout of IBS and you're just like lost, not interested in any discussion, not interested to smile. And when someone tries to like engage you in the conversation or whatever, you just give like and sometimes some people, and this happened to me. Sometimes people misunderstand you, and this is another bad thing. Misunderstand you. Just
شكلها مخلص بقى ايه. اوكي. الموضوع نظيف.
Can you hear me, guys? Can you hear me?
Yes, we hear you.
Okay. So here we're going to discuss the exogenous erythropoietin. It's been used since 1985 for patients with anemia of end-stage renal disease and also commonly used in cancer patients. So depending on the symptom, it's advised for hemoglobin is less than 10 gram per deciliter, and we need to monitor hemoglobin weekly to avoid iatrogenic polycythemia. And there is one consideration that we should put in mind before prescribing such synthetic erythropoietin as a poietin alpha, that we make sure that ferritin is optimum level, because they found that in many articles that publish in PubMed and other respective journals, that people with suboptimal ferritin level, they achieve suboptimum uh, response to erythropoietin. So before prescribing this medication, we need to optimize the ferritin level to achieve the best response. And according to Medscape, regarding prescribing erythropoietin in patients with CKD, they divide it into the patient that CKD on dialysis. We initiate treatment if the hemoglobin less than 10 gram per deciliter, and if hemoglobin level approaches or exceed 11 gram per deciliter, we can reduce or interrupt the dose. But the patient who have CKD not on dialysis will also initiate at the same level less than 10, but if the patient hemoglobin level exceed 10 gram per deciliter, we can reduce it or interrupt the dose. And because as we know that erythropoietin, synthetic erythropoietin has a lot of side effects, and one of them, the fearful one, is the malignant hypertension. And if the patient achieve no response or no reticulocyte response in 46 weeks, we can discontinue therapy. Uh, Other causes of anemia is pancytopenia. So pancytopenia without iron deficiency erythropoiesis suggests marrow failure due to interference with proliferation of hematopoietic cells. And common causes could be drugs such as chemotherapy and immunosuppressive medication. Also, immune damage to stem cells, intrinsic marrow lesions, and marrow replacement by malignant cell or fibrous tissue. So we can do further investigation here, bone marrow aspiration and biopsy. Other cause is pure red cell aplasia, which isolates suppression of erythropoiesis and could be of an inherited and congenital cause, which is known as diamond black fence syndrome, and could be acquired in elderly because of some medications such as trimethoprim, sulfamethoxazole, and infection, which most importantly parvovirus B19. And they found that there is association between pure cell aplasia and some malignancies such as thymoma and lymphocytic leukemia. So if we found someone that has pure cell aplasia, we should put in mind to further investigate thymoma and leukemias. Regarding macrocytic anemias, we have pernicious anemia. It's a cause of megaloblastic anemia, but here it's isolated because it's an autoimmune disease that attacking the parietal cell of the stomach, leading to deficient of acidity, lead to achlorohydria. Sorry. And also intrinsic factor, which is important to bind with B12 and help its absorption in terminal islum. So we need to detect pernicious anemia as a cause of B12 and megaloblastic anemia because it has own consideration in management. If we decide to give them oral B12, we need to increase the dose rather than other causes of megaloblastic anemia. Then we have other causes of megaloblastic anemia that show the sign of pancytopenia, macrocytosis, hypersegmented neutrophil in peripheral smear, and decrease the reticulocyte index. And one of common medications that causing megaloblastic and B12 deficiency is metformin. So also when we do medication review of patient and showing those signs, we should consider metformin one of the causes. So microcytic anemia in older adults usually results from B12 and folate deficiency, but low B12 and low folate do not necessarily show microcytosis or anemia. Here we have microcytic anemia, we have thalassemia. We surely here we're talking about thalassemia minor or thalassemia trait, because thalassemia major would show in early and younger population in pediatric. But here the minor would be silent and would show in elderly because of additive stress, as we mentioned before, the aging process and hemopoiesis processing. So we need to do further investigation, such as blood film. We can see the target cell and hemoglobin electrophoresis. We have also acquired plastic anemia, which is primary disease of older adults. It shows heterogeneous group of disorder marked by ion deposit in mitochondria of normoblasts. It could be as part of lead poisoning or inflammation of the
Salam alaikum, Dr. Ayman, can you hear us? I think there's an issue with your connection. We can't.
No, I don't hear anything. Hello?
Yes, we hear you, but we can't hear Dr. Ayman.
Okay, thank you.
Dr. Ivan, can you switch your mic again and see if you can hear it? You can use the chat if you can't hear you.
Okay. I will check with him. If he have any technical problem, I can continue the presentation. I'm just trying to set up my computer.
Sorry, everyone. Dr. Sana messaged me that you couldn't hear me from slide 24 because I was being kicked out from the Zoom meeting. So I'll go back. Can you hear me right now?
Yes,
Yes, we
hear
can,
you.
Dr. Ayman. Yes, we can.
So last slide, as Dr. Sama told me, you can hear me at this slide, right?
We can't see your screen yet.
Okay. Can you see it now?
Yes.
Okay. Did you hear this slide or the one after?
Yes, this slide.
Yeah, okay. I mentioned that in this slide, we're continuation of discussing the other different type of anemia that occur in elderly. So one of the most important autoimmune hemolytic anemia, as we recall, the autoimmune hemolytic anemia, we divide it into warm and cold. So the warm autoimmune hemolytic anemia, which is associated with IgG subtype, it's associated with some of the malignancies like non-Hodgkin lymphomas and CLL and SLE and some medication as alpha-methyl dopa and beta-lactam. In this type, we could use corticosteroid, and in refractory disorder disease, we consider splenectomy. But in the cold subtype of autoimmune hemolytic anemia, we consider only cold avoidance, and in some certain circumstance, we consider rituximab. So we're going to microangiopathic hemolytic anemia, which is mechanical destruction of the RBCs by small thrombus occurring with small blood vessels. It could be secondary to DIC and also TTB and HUS. And also there is macroangiopathic hemolytic anemia and associated with common disorders in elderly as severe aortic stenosis and prosthetic heart valve. Here, going back to B12 and folate, as we see here, could be the low level of B12 and folate could be of a norm in elderly who showing no macrocytosis anemia or increase in some of the metabolite as homocysteine or macrocytosis. In the diagram show 10% have B12 deficiencies and 5 and 10% have low folate without being sick. So we need to know who's going to, which patient we're going to replace with folate and B12. So in older adult patient with low to normal B12, we should check methylmalonic acid level to exclude metabolically active B12 deficiency. And in severe B12 deficiency and possibly mild low level can result in cognitive impairment and significant neurological deficit. Despite no link between low B12 and dementia, and as we all know that we consider it in clinical practice that B12 deficiency and hypothyroidism and depression and normal pressure hydrocephalus associated with reversible cause of dementia. So we should, despite the no evidence, we should aggressively replace B12 and folate in such patient. So low B12 or folate is accompanied by increased homocysteine. So in such patient, because homocysteine associated with worsening of coronary artery disease, so we need to decrease homocysteine by supplying 400 microgram folate once or twice daily. Or in patient who require B12 deficiency, B12 replacement, if they show that methylmalonic acid level is elevated, or even if they show that no anemia, but they have macrocytosis and low to normal B12, in addition to neurological changes, we need to consider replacement therapy. We can consider 1 milligram daily of oral B12 in general, sufficient for patient with low to normal B12. And also parenteral replacement for B12 less than 100 picogram. So I'm going to stop here and give the stage to my colleague, Dr. Maha Babakar, to continue the presentation.
Okay, thank you, Dr. Ayman. Hello, everybody. I will be proceeding in this presentation. And now I will be talking about the effect of aging on platelet and coagulation. So it's very interesting to know that platelet count do not change with age, and the concentration of, but the concentration of many coagulation enzyme increase. Example like factor 7, factor 8, and the fibrinogen. And the studies show that aging actually increase the coagulability status. Okay. Now we will talk about the bleeding deficits. It's not uncommon in elderly. For example, we see a lot of unexplained bruises in old people. Surely it could be as a reason for skin change and collagen and change in collagen in their skin, but also we can't forget that it can be related to bleeding disorders. Moreover, it's also uncommon to see, it's also not uncommon to see repeated nosebleed and GI blood loss. Additionally to excessive blood loss during surgery or following a toothache extract. In this case, patients should have a screen for platelet count and coagulation study. Platelet aggregation test is also important to be checked in this case. Now we'll move on and talk about specifically about the thrombocytopenia. And it's good to know that platelet count below 150,000 per ml is considered to be significant, but the bleeding don't occur usually till it's much lower level of platelet count. And the treatment for thrombocytopenia depends mostly on the cause. So basically, for example, if the cause is decreased platelet production, in this case, we will consider platelet transfusion, especially if there is a lot of significant blood loss. And if the cause for that thrombocytopenia is increased peripheral destruction, for example, which can be related to. Is anybody have a comment? Or? Okay, so like somebody forget his microphone on. We will proceed. In case, I will share my screen, Dr. Ayman, from here. So. Okay. Okay, I will be sharing the screen. Okay, we was discussing the treatment and the causes for thrombocytopenia, and we was talking about the last one, which is if the cause for thrombocytopenia is isolated thrombocytopenia, we need to exclude MDS, and also we need to consider DIC and TTB. Platelet function disorders. Platelet function disorder, which we call thrombobiasis, are uncommon, but can cause significant bleeding, especially in elderly who are using aspirin therapy, sometimes requiring platelet transfusion. And the first topic, or the most common topic in this group, is the variable brain disease, which could be hereditary, can present initially in older people, or could be acquired disease of elder people. Commonly, it could be associated with molecular gammopathies, lymphomas, and myelomas. Desmopressin acetate may be used when treatment is necessary. If there is any adverse effect or the patient cannot tolerate it, then we can move to factor 8 concentrate that have high dose of variable factor. Clotting factor deficiencies. The clotting factor in elderly, most commonly, the problem is acquired inhibitor to factor 8, which is happen suddenly, and also we're going to find a high titer of anti-factor 8 antibodies that can be very high. And as presentation, it presents with bleeding into joint and muscles besides factors. Okay, in that case, then factor replacement therapy and prednisolone, cyclophosphamide may be needed. The other causes for clotting factor deficiencies in elderly is deficiency of vitamin K dependent clotting factors, which tend to occur in older people with major illnesses. Consider inappropriate warfarin used, or maybe the patient is on warfarin and he's taking extra dose or something. And the treatment for this situation will be vitamin K. Excessive bleeding and liver diseases. We consider liver disease in all patients who present with excessive bleeding. And we also find in those patients prothrombin time will be prolonged, even if the condition of liver disease is very mild. Liver disease reduces all clotting factor except factors 8, result in leg clearance of fibrin degradation product, and it also can affect the platelet function. Also, liver disease is associated with DIC. Treatment of bleeding deficits in liver disease is fresh frozen plasma. Now we're going to move on to chronic myeloproliferative disorders. And it's good to know that the Philadelphia chromosome negative chronic myeloproliferative disorder occur primarily in older adults. Examples of those disorders are the polycythemia vera and the essential thrombocythemia, idiopathic myelofibrosis. The essential thrombocythemia and polycythemia vera have a long natural history and have low incidence of leukemia transformation. and over 90% of the polycythemia patient have JAK2 V671 F mutation, and it's very good screening test. Management for polycythemia vera is, firstly, we do risk stratification in the incidence of polycythemia vera and essential thrombocythemia. Phlebotomy is the first treatment we do for those patients, and the aim is to keep the hematocrit below 0.45. Antithrombotic therapy with low-dose aspirin can be also used, and cytoreductive therapy in patients with high red cell mass and frequent phlebotomy. Hydroxyurea is the agent of choice in this case. And for essential thrombocythemia, the management is observation for asymptomatic who are low-risk patients and with platelet count less than 1,500 over 10, and hydroxyurea plus low-dose aspirin for high-risk patients. Okay, now we're going to summarize all the topics that we talk about today. And in summary, the reserve capacity of hematopoiesis is diminished with advancing age. Anemia is the most common age-related hematological abnormalities. It should be evaluated in the same way as in younger adult. In older adults, the most common cause of iron deficiency erythropoiesis is anemia of chronic disease and anemia associated with inflammation. Also, we mentioned that vitamin B12 deficiency and low folate are common in apparently healthy adults over 70 and can be clinically important. Patients with bleeding diaphysis should have a screening for platelet count and coagulation study and platelet aggregation test. Platelet count less than 150,000 per ml is significant for is significant. Clotting factor deficiencies in older adults are usually acquired and are caused by circulating clotting factor inhibitors. Acquired sideroblastic anemia, myelodysplastic syndrome, and Philadelphia chromosome negative myeloproliferative disorder occur primarily in older people. Now we have about 3 cases just to make sure that we understand those information we mentioned. The first case is about 75-year-old man come to the office for routine examination. He feels well. He is in hemodialysis for chronic kidney disease. He have a history of long-term type 2 diabetes and peripheral vascular disease and coronary artery disease. Medication include insulin, metoprolol, and sevelamer, and calcitrol. Examination is unremarkable. Laboratory result, the BUN is 20 milligram per deciliter, creatinine is 6.5 milligram per deciliter, sodium is 140 milliequivalent per liter, and potassium is 4.4 milliequivalent per liter. His hemoglobin is 9 gram per deciliter. So the question is, which of the following is the most appropriate next step for this patient? Began abutine alpha with a target hemoglobin concentration 13 to 14 milligram per deciliter, or begins abutine alpha with a target hemoglobin to be between 11 and 12, or begins abutine alpha if hemoglobin concentration falls below 9 milligram per deciliter, or begins abutine alpha if symptoms develop. I will be watching the answers on this in the chat section. Okay, that's great. That's great. And the answer is, okay. Oh, just okay. Sorry about that. Okay, and the answer is B. That's good. That's very good. The second case, does anybody have a question about that, about this case? Okay. The next
Hi.
case. Yeah,
Yes.
hello.
Assalamu alaikum. So, what is the cutoff? Is the 9 milligram per deciliter is the cutoff for chronic disease to
No,
start erythropoietin?
no.
Okay.
The cutoff is between 10 and is 10. The cutoff is 10. So
Okay.
yeah.
Yeah, I can answer here because as I mentioned in my part that according to Medscape and other references PubMed, they show that they start medication if the hemoglobin drop below 10. So anything above 10, just watchful or observation, but below 10, you start management. But according if the patient on dialysis or not, the target will change. If on dialysis, you need to get the target till reaching 11 or to 12, but it's okay if the patient is CKD patient, but not on dialysis, so we can above 10 is acceptable. But initiation the management when the hemoglobin below 10.
Yes, and in this patient, the hemoglobin was 9, so it's definitely below the cutoff.
Thank you so much.
Okay, you're welcome. Okay, now we're going to move to the second case. It's about 89-year-old man present to you complaining of generalized weakness. Generalized physical examination and neurological examination are normal. He lives with his wife in a rural community, is independent in ADLS and IADLS and rarely drives. He has avoided medical care for most of his life. He is on medication other than he is on no medication other than calcium, vitamin D, and aspirin 81 milligram a day. His laboratory test, his hemoglobin is 11.9 gram per deciliter, hematocrit is 35%, and the MCV is 102. Serum B12 is 200, which is low. Normal, but is a low normal. Methylmalonic acid is 300, is high, and homocysteine is 18. It's also increased micromole per liter. RBC's folate is normal, and ferritin is 250 nanogram per milliliter. So the question is, what is the next step? Prescribe oral vitamin B12, 1000 mcg per day, or administer of B12, 1000 mcg IM weekly for 8 weeks, followed by 1000 mcg IM monthly, or administer of 3-bar chilling test, or recommended upper and lower endoscopy to exclude pernicious anemia and bacterial overgrowth syndrome. Okay, what is the answer? Okay. All right, B, B, D, A. Okay. Okay, let's see the answers. Look like we will have different answer for this one. And the answer is A, prescribe oral vitamin B12, 1000 mcg per day. Okay, does anybody have a question about this? Why it's A?
I can explain a bit because I see like different answers.
Mhm.
Also, as before, here is a tricky question because they use microgram per day, which is I mentioned before, it's 1 milligram per day, which is the same.
Yes. Mhm.
Practically, clinical things we examine for pernicious anemia. In the past, they use Schilling test and other tests, but currently they use antibodies. So if you are suspecting that the patient has a feature of achlorhydria, like gastritis and things, we can check with antibodies, anti-parietal cell or anti-intrinsic factor antibody. But in general setting, we start first with prescribing oral B12 1 milligram per day, which is equivalent to 1000 microgram per day.
Okay, that's great. Thank you, Dr. Ayman. Does anybody have any more question about this case?
Yes, hi. So we don't need to exclude the causes of the vitamin B12 deficiencies. We start treat right away.
Yeah, as I mentioned before, in all causes anemia, you need to seek the risk factor because you want to stabilize the risk factor. in concomitant with treating the disorder. So the risk factor might be side effect of medication, or could be like autoimmunity versus anemia. So depending on the suspicion, you go after. But in general, we're prescribing oral because most of elderly patient could suffer from low B12 deficiency, and the cause would be idiopathic. So we could correct.
Okay, thank you.
Okay, now we're gonna move to the last case. This case is about a 72-year-old woman is referred for evaluation of erythrocytosis. She reported no fever, chills, sweat, vertices, visual or auditory disturbance, headache, or dyspnea. 2 episodes of dizziness a few months ago resolved after several minutes. She is Ashkenazi Jewish background, but there is no family history of hematological disease. She smoked 1 pack a day for 25 years, but quit 20 years ago. On physical examination, she appeared plethoric, but she is not acutely distressed. Temperature is 36.2 Celsius. Blood pressure is 166/98. Pulse is 91 beat per minute. Respiratory rate is 14 breaths per minute. The spleen is identifiable by percussion and just palpable at the costal margin. Laboratory studies. A year ago, her hemoglobin was 16.4 grams per deciliter, and erythrocyte count was 5 multiplied 106 microliter, and leukocytes count is 10,600 microgram per liter. Last month, her hemoglobin was 17 grams per deciliter, and currently her hemoglobin is 18.2 grams per deciliter. Leukocytes count is 13,000, and platelet count is 454. Erythropoietin level is below 2, which is low, considered. Serum iron is 30 microgram per deciliter, and ion binding capacity 324 microgram per deciliter. Oxygen saturation on room air is 94%. The question is, which of the following is true of this patient? She is likely to die in 5 years from fibrosis, or she is likely to have prolonged survival with therapeutic phlebotomy, or she is likely to have a major thrombotic complication such as a stroke and Budd-Chiari syndrome, or she is likely to die in 5 years from acute leukemia. And let's see what everybody answered. Okay. A, okay, C, B, that's good. Some people answer C, some people answer B. C, okay. Let's see what is the answer. And the answer is B. She is likely to have prolonged survival with therapeutic phlebotomy. So basically, before we say why the answer is B, the answer, if we look at the lab test, she having polycythemia vera, right? So she have all the cell counts high. Polycythemia vera patient, we mentioned earlier in the discussion that they are tend to have prolonged life, and the first thing we do to them is phlebotomy. And that's why we're not going to jump to be like. And also, if you look at the answer here, we have, she is likely. Likely, it's mostly likely, when they say she is likely, that means it's not a complication. What is the most common thing for most of the patients with polycythemia vera is to survive with no problem with therapeutic phlebotomy. And that's why the answer is B. Does anybody have questions for us? Okay, it looks like everybody get this point. So thank you, everybody, and that's all for our presentation for today. Now we're going to move to the next topic with Dr. Ali, and it's all yours. The stage is yours, Dr. Ali. Thank you.
Assalamu alaikum, everyone. My name is Ali Metwaly. Thank you, Dr. Ayman and Dr. Maha, for your presentation. Today, I will present 3 topics. The first one is impostor syndrome. Let me share the screen. Okay. Do you see the screen now? Is
Yes.
my-
Yes, we do.
Okay. Okay, so imposter syndrome is also known as imposter phenomena or fraud syndrome. Usually in high achieving individual who, despite their objective success, they are failing to internalize their accomplishment and have persistent self-doubt and fear of being exposed as fraud or imposter. They feel that they aren't as competent or intelligent as others might think, and soon enough, people will discover the truth about them. So usually, those individuals are success in their career, but they are feeling that they are not fit or qualified for this position or this success.
Sorry for interrupting, Dr. Ali, but we only see the first slide.
Okay, just a second. You only see the first slide?
Yeah, now it's good.
Now we can see.
If you can use full screen, that would be
Okay,
better.
let me check the full screen. Okay, so you see the screen now? You see the screen?
Yes, we can see.
Okay, so second slide. Okay. So it first started with two psychologists, Pauline Rose and Glantz and Sussman Ames. They identified the imposter syndrome. The imposter syndrome can affect everyone, regardless the gender and job or social status. But usually it's more common in high achieving individuals. Around 20 to 30% of high achievers may suffer from imposter syndrome, and about 70% of adults may experience imposterism at least once in their lifetime. We can divide the imposter syndrome. It can be broken into 5 basic types. Do you see this slide or?
Yes.
So the 5 types is perfectionist. So perfectionists set extreme goals for themselves, and when they fail to reach the goals, they experience anxiety, self-doubt, and worry. They feel like an imposter because their perfectionist triad makes them believe that they are not as good as the other might think they are. Second type is expert. Never feel satisfied about what they are achieving, especially because they always want to learn more and fear of being exposed as inexperienced or unknowledgeable. The natural genius, the third type, believes they are natural intelligence or competent. So if they don't get something right the first time, or if they take long time to master something, they feel ashamed. The soloist fear asking for help will reveal their incompetence. So usually they don't want to ask any help or any questions. They may turn down help in attempt to prove they are the self-growth. The super person, this type of imposter syndrome, believing that you must be the hardest worker and reach the highest level of achievement possible. If you don't, you are a fraud. So the imposter syndrome affects the person's life in many aspects. First, it can affect his work performance. It can affect responsibility. He can make himself doubt about his success. And he can attribute his success to outside factors like luck, job dissatisfaction, and burnt out. Avoid seeking promotions and focus on task and goal setting, and it can affect his mental health. No diagnosis available for imposter syndrome. According to Diagnostic and Statistically Manual of Mental Disorders, 5th edition, there is no list of criteria to diagnose imposter syndrome. How to overcome imposter syndrome? First, you must know and celebrate the achievement to build confidence and counter imposter feeling. Challenge negative talk and understand inner critic and practice self-compassionate. Seek support and mentorship from your peers and your friends and your family to overcome self-doubt. Focus on continuous success. Cultivate celebration mindset. So you need to celebrate the success and take pride of your achievement. Promoting positive self-belief and in preventing the imposter syndrome. So there is some tips that will help you. You need to you can start your day every day with positive affirmation to boost the self-worth. Break down the large goals into smaller, achievable tasks. Prioritize self-care activities like exercise, nature time, reading, and mindfulness. Create support network of positive individuals. Practice self-compassionate, treating oneself with kindness. Celebrate even the most minor victories throughout the days. Acknowledge of tasks completed and the new skills learned or positive feedback. And remind yourself of the past achievement all the time and the obstacles that you overcame. Embrace failure as an opportunity for learning and the growth rather than reflection of your ability. Okay, so this is the first topic. Does anyone has questions? No? Does anyone have question about the first topic?
No, thank you, doctor.
So second topic will about how to edit photo. You see my desktop screen?
You can unshare and then share again.
Okay. Now I'll discuss about how to edit photo. So usually I use the Paint program. It's easy. You can find it on the Windows. So you can right click on any photo. You can click edit. So first, how can we check the size of the pictures? If you click on resize, it will show you the pixels. This is the horizontal and vertical to know the actual size of the pictures. If we need to crop a picture like part of the picture like profile, or you can click in this select from here. It's rectangular selections, so you can select the profile, the picture you want, and you can click on crop. So the picture will be cropped like this one. Or you can use the freeform selections from here. If you want to crop like some part, just part of this, and you can click crop, it will show what you are selected. How can we resize these pictures if it's big and we need small size, like to put on profile, like Eros or any social like LinkedIn or Twitter? So you can click on resize the picture here. So we can resize the picture by percentage or by pixel. So if you want the picture like be less, you can put like here like 50, so it will be smaller. We have, you can select maintain aspect ratio if you want to stay the ratio like the same, or you can. So now the picture is smaller. How can we save the pictures? You can click on File, Save As, and click on JPG Pictures. This selections makes save the photo quality, good quality. So it's better to select this option, as it will make high quality for the picture. And you can select anywhere like desktop and save it. Does anyone has any questions about editing photo? So I can explain, but this is the most common you need. And also you can click on rotate if you want to rotate the pictures any degree, like 90, or if the picture is not straight. Does anyone has any question about editing photo?
Thank you so much, Dr. Halif, and
Yeah.
thanks to all the presenters. So
The next one is the last one. Is
go ahead.
the last presentation will be about virtual interview. So let me share the screen. Can you see my screen now?
No, we're still on the end.
Okay. Sure. Can you see it now, the virtual interview presentation?
Yes, we can see it now.
Yes, we can.
Last 2 years, the interview started to be virtual due to COVID. First, I will discuss about what's the pros and cons of virtual interview. So for the pros, first important is the travel cost. With the virtual interview, so you can save the cost of the flight, so you can do the interview anywhere. You can do at your home country, so you can save the flight tickets, and you can save the accommodation, the hotel, so it's cost effectively. And you can do many interview in the same, like close together. So before, usually the interview, like when it was in person, so you collect area like zone of United States, so the Northeast, to do the interview at the same in certain amount of time, and after that you do the like Midwest or go to the Pacific area. So now you can do any interview maybe like in the same next week or next day, and it's convenient. So you can do at your home, so you save time. And also the mock interview, you can practice with your friends the interview. It will be the same app use. You can use Zoom with your friends, so it will be the same. The cons of the virtual interview, you have you inability to meet the resident. So during the virtual, you can't meet all the residents. You can so you won't be aware of the other resident. and you can observe the interaction between the resident together and the interaction between the faculty and the resident. And during the virtual, you will lack the opportunity to tour the hospital facility. So you're not aware about the other department in the hospital and how the hospital is working. And you can't observe the city or the weather or the housing.
So I don't want to interrupt you, Doctor, but
Yeah.
we only see the first slides. We cannot see the other slides.
What first slide?
We only see the first one.
Okay. Sorry for. No, it's not sharing. Okay, so you see the second one?
Yes, we can see the second one now.
So the cons, it's you can inability to meet the resident in person. So you can't meet all the residents, you can't meet all the faculty, you can't tour the hospital facility to see the other department and how the hospital work. So you are lacking the feeling that you will able to work in this place, or you can't be working. And the city also, the hospital in the city you haven't visited before, you don't know the city, you don't know the weather, you don't know the housing arrangement, so you lack a lot of information that will help you later when you rank the programs. Now I'll talk about the positions and lighting. So it's important that you have good source of lighting. Lighting, it's better if you have natural light, and the camera, it's better to be behind the desktop or laptop, so you don't have any shade or darkness in your face. And you need to have comfortable chair as you will sitting for a long time during the virtual interview, and the desk. And it's better to have the laptop, it need to be on the desk and unstable and fix it, so it won't move during the interview. And the background, it's be like blank background, like white wall, or business background, the professional one.
Excuse me, Dr. Ali.
Yeah, you can see this presentation.
I'm seeing it, but we're still in the second slide. Can we move? Yes, we see
Okay,
you.
just a second.
Right now.
Yes, we see the third slide. Yeah, thank you.
So the background, you can use white wall or professional background. Try to avoid using mobile devices for the interview, as it won't be stable and it will be moving. And try to not sit on sofa or bed. It's better to sit on chair and the laptop on the desktop. And try to avoid professional background. So try to avoid any distracting image or image distraction in the background. So the requirement, can you see this slide or the requirement?
Yes, we see it.
Okay, For the virtual interview, the requirement you need to have laptop and desktop, and be sure that the laptop is working fast and all the apps working on the laptop, and to have camera. To check your camera, you need to check your camera. It's the good resolution, or if your laptop resolution camera is not good, you can buy external camera. And be sure that your microphone is working, and you need to have good lighting during the virtual interview. You don't have to buy external light, just the room light is good if it's efficient. And be sure that your internet speed is high, so to avoid any interruption during the video conference during the interview. And you need to have desk and comfortable chair and a quiet room, to be sure that you doing the interview in quiet room, to avoid any distraction or any noise. And the background can be blank or professional background. And you need to have the interview suit like the suit you are wearing in person. For pre-interview social events, you can use semi-formal business casual. Also, you need to have any backup devices in case the laptop is not working or any problem in connection. You have to backup devices. During the interview, you need to be sure that you have water and coffee and drinks. So the interview sometimes stay for long hour, like 3 or 4 hours or more, to have your water beside you if you need to drink or coffee, and have snack or meals. So the video conference software. Usually the program coordinator will send you the link about the software that you will be using during the interview. The most common one is Zoom. You can use Microsoft Teams or any other programs. They will send you the meeting link. It's better to be sure it's the day before that the link is working, so to avoid any problem in connecting during the time of the interview. And download the software that you will be using during the virtual interview, and be familiar how to use the software, how to turn off the video, how to turn mute or unmute during the interview, to avoid any delays. And always to be familiar how to use the software, like raising hand if you want to ask questions, or how to click on the chat box and how to select the participant name to see who is participant in this interview. During the interview, you need to watch your behavior, as they are watching you all the time, even you are not talking or not asking you questions. The residents and the program coordinator is watching you. So avoid during the presentation. Most of the interviews start with presentations about the program and information about the program. So you need to be aware and pay attention and focus what they are saying. Don't yawn or play on your phone or get distracted during the presentation, and avoid to look bored or interested what they are saying. And you need to pay full attention and smile and show that you are interested about what they are saying and about the program. Don't interrupt anyone during the interview. To stop anyone while they are talking, you need to wait till they are finished the presentation and ask them the questions. And mute yourself if you are not talking or asking questions. You need to mute yourself, and be sure that your video is on all the time during the interview, even while they are doing the presentation or between the interview. And be sure that you put your full name during the virtual, put your name on the Zoom to be the same as Eros account, to be sure so they know who they are talking to during the presentation or the interview. So during the interview, first you need to start about the interview, the greeting. So you can say, hello, how are you doing? How are you? It's my pleasure to meet you today. This is the beginning of the interview. Be sure that you have good eye contact. So most of the time, look into the camera and be sure the camera in your eye level, and watch your body language. So don't move your hand a lot or raise your hand during talking during the interview, and smile most of the time. Avoid too many body movement during the interview, and at the end of the interview, you need to thank the interviewer about the interview today. Be sure to write the name of the interviewer, so after that you know who interview you, so you can email them or send them thank you letters later. So it's important. After you finish the interview, you can ask the program coordinator to provide you the email of anyone you had interview with. So after the interview, you need to post-interview communications. You can send the email or card for the program to thank him about the interview, and be specific about what you need to talk about. If you talk about something specific during the interview, you need to mention this in the email so he will remember you. Or you can send a card to them, and be sure to ask the coordinator about the mailing address to be sure that they will receive your card. You need to send this email or card to the program director, the program coordinator, all interviewer, attending, or any resident you met during the interview. Don't send email or card, thank you email or card, if they ask you to don't do this. So I have like some other tips we can discuss before. So be sure to ask the program coordinator about the phone number and the email address in case you have problem connection, or if you have something emergency or something happened during the interview, so you can call her to inform her about the problem. Okay, does anyone have any questions about the virtual interview? Or Does anyone has question about the virtual interview? Do you hear me?
Thank you so much.
You're
Thank
welcome.
you, Doctor.
Okay.
This was very informative. Thank you.
Thank you so much.
You're welcome.
Thank you all the presenters for from today, and really appreciate your effort and your great work. Thank you so much. Any questions for any of the presenters from today? If not, we can go to the next agenda. Any updates as far as ideas, projects going on? Go ahead, Dr. Mossad.
Good evening, everyone. I hope everyone is doing good. Thank you for the presentations today. Regarding the updates, I'm glad to share that we had a paper accepted as an abstract in the American College of Gastroenterology. The paper was COVID-19 and pancreatic disease among geriatric population. This would be presented as an abstract in the Vancouver, Canada, as a poster by Dr. Ayman and Maha, inshallah, and congrats to everyone in the team and congrats to Nader. The second update is that regarding the pediatric vaccination app, we had the issue about the minimum about the 10 users. I'm glad to say that we overcome this issue. I had to change something in the settings, and now anyone that uses the application can just log into the app without signing in, and they will have access to everything in the application, from the recommendations to the informations, without having to sign up. So the user's number will not be added as 10, and we will never reach the maximum, and the app will be running and functioning to everyone. And thank you.
How much? Great job. Congratulations to you and your team on board for it. Dr. Osama, go ahead. Dr. Osama, go ahead.
Thank you so much, Dr. Nader, and hello everyone. I'm just feeling excited. I'm glad to share with you that last week I have one paper that been published on Curious, and I was working on it for maybe like 3 months. It was so hassle, I mean. So, but I guess I want to let you know that once you choose your project, go ahead and everything will be fine. And good luck for everyone. Thank you.
Excellent. Thank you so much, and congratulations. What's the title for your paper?
The title was The Effect of Serotonin Type 7 Modulation on Smooth Muscle and sensitivity and bowel sensitivity in patient with irritable bowel syndrome.
Excellent. Congratulations again.
You're
Thanks
welcome.
for sharing.
You're welcome.
Yeah, good luck to everyone. Anyone else wants to share or any questions?
I have a question, Dr. Nader, if you don't mind.
Yes, go ahead.
Yeah, I want to know if there is any like input or advice about conferences that one should be careful about, or some point we need to know about when if we go like I got like invitation from one conference to speak about my paper, which I just told you about. So now I didn't give any reaction. So if there is any like advices about conferences, types of conferences, or any like advices, that would be appreciated. Thank you.
Sure. Thanks for sharing and the question. So basically, there are some people out there, they try to take advantage of people like you. When you publish a paper or when you go to a conference, most of your data will be available to the public. So there are some companies or some people out there, they will try to contact you to, as you mentioned, to invite you to talk about whatever in your paper or your presentation class or your topic. So how to differentiate, how to tell if this is legit or if this is good conference or not? There are options. One of them is when you look at the invitation, mostly it will be an email sent to you. Most likely you will have some error, some mistakes there that are not indicating that the person is not a professional. They are just trying to mass produce these emails to take advantage of you. Number two, most likely you will have the contact information overseas. It's not here in the US. Number three, if you look at their website or some, they may not be legit and they don't have good history. Unless you have good investigation, like you go to their website and you investigate, you ask Google about their legit, how long is the website there, and look at previous conferences, see who attended, who presented what topic, and review these presenters' CV and resume, and Google it. So if they say Dr. Maha has published the paper on this, and she presented a talk on this last year, you go and look at Maha's CV and see if she mentioned that in her CV, for example. Or if it's there is a combination between the name and the conference in the past. Most of the time, if it's legit, you will find this information. There is no contradiction. But if you find it difficult to match, then you must be cautious about this. I got a couple of them. I got some to publish in journals, and I got some to attend conferences overseas, China, Japan, somewhere. And so I just disregard this. At your level, I don't think it will benefit you to go over these conferences unless it's here in the US and it's valid and you have some way to attend in person to make connections and see if this can help. Otherwise, if you get an invitation just for you, be cautious in handling this. I hope this will help you.
Thank you so much, Dr. Nad. That's so informative. Thank you.
Any other questions or input or updates? So last week we talked about how to develop a simple app using the Glide app, just to get the basics of developing an app. And you can mention that in your resume. You can talk about it in your video interviews. So I try to create a template for you guys so that you can also start from not only from like the basics, but from somewhere instead of from scratch. Can I share with you So if you go to this website, I'm going to share it also in the chat. So basically, this is the app that I developed last week, and I added some details like I added some languages for the user, so the user can select their language, and depending on which language they go and get all the information and so forth. So if they want to add more information about their blood pressure, they want to get more information about their app themselves, or the condition hypertension. It can be in Spanish as well. It can be back to English. So you can look at all this. So this is just a simple way of developing an app. For you to start, you can create an account with Live app, and then you go to this website. You click on copy in Live, and it will copy this app for you. When you are there, it's going to be somewhere similar to this one here. So you get the data, and you can modify from settings. So you can change the name, you can change the appearance, you can change the privacy, user, everything you can change here. And then you can change the layout if you want. There are different things that you can do. So this is just a way of helping you if you want to develop an app on a template, which is an easier way. And like apps, they have a lot of templates that you can work on to, let's say, you want to develop something about blood sugars. You can do that. Educational materials, you can do that. Any other ideas you can develop, you can work on something that's simple, and then using the tools and right out, you can modify it and make it more advanced version, if that makes sense. This one aspect when you can develop and you can talk about. So any other questions or any other comments? If no other comments, then I'd like to thank you again, all the presenters, and I'd like to thank all attendees from today's meeting. We will see you next week, inshallah. Let me know if I can be of any help. Shoot me an email or send a text or call me if you have to answer. I wish you all the best, and Assalamu alaikum. See you next week.
Thank you, Dr. Nadia.
Thank you, Dr. Nader.
Thank you very much.
Thank you, Dr. Nadia.
Thank you,
Thank
Dr.
you so
Nader.
much.
You're welcome. Thank you.
Thank you
Have
so
a good
much.
Have a good day. Bye-bye.
Thank you, Dr. Nader.
Thank you so
Thank
much.
you very much.
Bye-bye.
Thank
Thank
you.
you.
Thank you, Dr. Nader.
You're welcome.
Assalamu alaikum.
Alaikum salam.